Hello everyone, today we'll be talking about LUDWIGS angina. My name is Dr. Stanley John. I'm from the Department of Oral and Maxillofacial Surgery. Ludwig's angina was first described by Wilhelm Friedrich von Ludwig in 1836. Ludwig's angina is a from acute bronchi toxic ciliatus of the submental space, submandibular, and sublingual space bilaterally. This is an emergency condition where you need to know its implications and manage it accordingly. So, coming to the etiology, odontogenic etiologies include dental abscess, periodontal abscess, pericoronal abscess, mandibular cyst that is infected. Iatrogenic include traumatic injuries to the orofacial region, osteomyelitis secondary to a compound mandibular fracture, submandibular or sublingual gland hiatus, and secondary infections from oral malignancies. Coming to the pathology, it is mainly caused by organisms that produce significant amount of hyaluronidase and fibrinolysin. So these break down to dissolve hyaluronic acid and fibrin respectively, and they spread the infection fairly fast. So microorganisms that usually involved are Streptococci and species of Staphylococci. Even E. coli are seen, Protella species are seen. Coming to the clinical features, the patient looks very ill and he is uh, toxic, dehydrated, pyrexia may be seen, anorexia, cheese, malaise, dysphagia, be able to swallow, he won't be able to eat anything properly. Impaired speech may be seen, his voice will be hoarse, and there's strong brawny swelling in the bilateral submandibular region and also in the submental region. This can extend down to the clavicle. And swelling is non-pitting, it is non-fluctuant. Severe tenderness may be present, his neck will be stiff. Ill-defined borders may be present with induration. He'll have trismus, that is difficulty in opening his mouth. His floor of the mouth will be raised and his tongue will be touching the palate. There'll be airway obstruction and increased respiratory rate, and so shallow breathing may be present. Cyanosis may occur due to progressive hypoxia, and fatal death can occur. So maintaining his airway is very important. So death is usually due to mostly due to airway obstruction rather than sepsis. So intraorally, you can see woody edema of the floor of mouth and tongue. The tongue becomes raised, and there's increased salivation. Thickness of tongue can be seen. There's backward spread of edema, and you can see the edema of glottis, which will result in complete respiratory obstruction. So progressive dyspnea can be seen due to this backward spread of infection. So primary management should be to maintain an airway for the patient. Coming to the principles of management, you should determine the severity of the infection, evaluate cost differences, that is, if the patient is immunocompromised or if he is diabetic, the spread of infection will be faster. Decide on the setting of care, what all, if, if even if you don't have adequate measures to treat it in your center, you need to be able to identify it and refer them to a higher center fast, support medically and treat surgically, give empiric antibiotics, don't wait for your culture and sensitivity. Choose and prescribe antibiotic therapy, should evaluate the patient frequently. CNS changes that you can see are decreased level of consciousness. You can see headache, stiff neck, vomiting, eyelid edema may be seen. Signs of toxicity include paleness, tachypnea, tachycardia, fever, appearance of illness, shivering, lethargy, and diaphoresis. So, indications of possibly fatal infections include respiratory impairment, there will be difficulty in swallowing, impaired vision or eye movement, change in voice quality, lethargy, decreased level of consciousness. So these are in stage of the disease. We need to be able to recognize this and manage it accordingly. when you're evaluating a patient, you should take a proper case history. You should see what is the cause for this. You should see if there is an offending tooth. It's very difficult to examine thoroughly because of this raised floor of mouth and trespass and all of that. So should do appropriate laboratory investigations. Radiographical evaluation should be done. Take an IOP. IOP will be quite difficult. You can also take a PG. You can take a lateral cephalogram to see his area and to what extent it is obstructed. You can take a CT scan or MRI. MRI is adequate to see the soft tissue and the amount of swelling that is present and what is the viable airway that is present. And even take an ultrasonograph. Blood investigations usually are required. The normal your TCD, CSR, C-reactive protein, all of this checks blood sugar levels. And you should also send his culture, his first for culture and sensitivity, but you should never wait for his test results. This might take 2 or 3 days. So empirical antibiotics should be started as soon as possible. Supportive therapies include administration of antibiotics, hydration of the patient. The patient wouldn't have eaten anything for the past 2 or 3 days when he comes to you in the OP. So hydration of the patient is important. You can even insert a rice tube and start feeding him. A protein diet should be given. Analgesics and bed rest should be given. Incision and drainage allows you to remove the toxic foreign material from the body, and it decomposes tissues and allows better perfusion of all these tissues, and also for the antibiotic to reach there better. So and this also helps increase oxygenation of the infected area. Coming to the principles of incision and drainage, you should incise in healthy skin and mucosa whenever possible. Place the incision in an aesthetically acceptable area. When possible, place the incision in a dependent position to encourage drainage by gravity. So, in case of a submandibular, in case of a Ludwig's angina, you incise on the below your mandible three positions at the segmental space and submandibular space bilaterally. Dissect bluntly using your sinus forceps. You should insert your sinus forceps closed, and when you insert into the incised area, and then open it up. And when you pull it up, you should pull it out. You should keep the beads open and pull it out so that you don't clamp onto any vessel and damage any blood vessels in the glucose. And you should always place a drain and stabilize it with sutures. So use of through and through drains in in bilateral submandibular space infection will be of great value. Do not leave the drain for an overly extended period. Remove when the drainage becomes minimal, and clean wound margins daily under sterile conditions to remove clots and debris. To conclude, incidence of morbidity and mortality has become very less nowadays because of the advent of antibiotic therapy. The key to a successful management is prompt therapy, early extraction of offending tooth, incision and drainage to shorten the usual course of infection to minimize the chances of development of further complications. So you should be able to identify a Ludwig's angina as soon as he comes to your OP. He's very ill and looks very sick. So if your facility doesn't have the adequate thing for you to give maintain airway, you should refer him as soon as possible. Fiber optic laryngoscope was preferred now, but it is not available in every center now. So even you can do a tracheostomy and begin tracheostomy under delay. The maintenance of airway is the most important thing, as that is mostly due to airway obstruction rather than sepsis. So, thank you.